Hey guys, I'm Sierra.
And I'm Laura, and this is our presentation on osteogenesis imperfecta.
Let's talk a little bit about the history and background of osteogenesis imperfecta.
Osteogenesis is a pretty rare disease. It affects about 1 in 10,000 to 20,000 people worldwide, and in the US, about 25,000 to 50,000. Considering that there's about 328 million people in the US, it's really not very common. Another common name, probably one of the more common names for this condition, is brittle bone disease.
There are two main cases of osteogenesis imperfecta that I would like to highlight. The first one being the earliest known case of osteogenesis imperfecta, which was a mummified infant that was found in Egypt that dates back to around 1000 BC. Another case is back in the 19th century, there was a Danish prince named Arvar the Boneless, boneless being after his genetic disease. And he was made well known recently through the TV show Vikings. Two notable things to mention about the history of osteogenesis imperfecta research is that the first studies on this genetic disease took place back in the 1700s by a man in Sweden. And then when it comes to really understanding the different types and categorization of osteogenesis imperfecta, the modern terms for the different types of OI come from research back in the 1970s by Australian physicians. Back in 1979, when Dr. David Sillens and his team defined the different types of osteogenesis imperfecta, they were only defining the first four. So they only knew of the first four. Since then, there have been roughly 19 forms of osteogenesis imperfecta that have been defined. On this slide, we're only showing the first 8. The two main ones of note are two of the ones that were defined by Dr. David Sillens and his team, which include type 1, which is the mildest and most often undetected form of OI. The most severe form, which is more often than not lethal, is type 2 osteogenesis imperfecta. While the types of OI that were defined back in the 1970s and throughout the years of research afterwards are still being used today, recently scientists have grouped these different types into 5 different groups based on the severity of their phenotypic issues. Still, type 1 is that mild case, and type 2 is the most severe case, the most lethal cases, whereas 3 through 5 or the more moderate cases that lie on the spectrum of severity.
So, what are the genetic components of this condition? How does it affect the genotype? And what are some of the inheritance methods?
Through various cases of osteogenesis imperfecta over the years, there have been nearly 20 different genes that have been found to have a mutation that results in OI. 85% of the forms of osteogenesis imperfecta, though, are actually from the mutation of the type 1 collagen genes COL1A1 and COL1A2. These two genes are what control the collagen in your body, and a mutation in these genes can cause the effects that we see in osteogenesis imperfecta. Some of these other genes include SEC24D and IFITM5. When it comes to how osteogenesis imperfecta is inherited, just as they have found multiple different genes that include mutations resulting in OI, there are multiple different modes of inheritance patterns that they've seen throughout the different cases. The first one being that autosomal dominant inheritance pattern, which is the majority of cases they see in osteogenesis imperfecta. These cases are specifically correlating to the types 1 through 5 of osteogenesis imperfecta, so a range between mild and severe forms of osteogenesis imperfecta. And usually, since they are that autosomal dominant inheritance, they're going to be heterozygous for the trait with one faulty gene and one normal gene. And these genes are going to either make the quality of collagen less, or they're going to make it to where the body's not producing enough collagen for the bones to really be as strong as they need to be. Another form of this pattern of inheritance would be autosomal recessive inheritance, which is less common than the autosomal dominant, but it is a case where it is always going to be inherited directly from the parents, whereas when we're talking about autosomal dominant, it could be that spontaneous mutation. These autosomal recessive inheritances correlate to types 6 through 18 of the patterns of inheritance, and just as it happens normally, about 25%, there's about a 25% chance per pregnancy that the parents will have another child with osteogenesis imperfecta, and the siblings have to be careful that they may be a carrier of the gene. And so it's something that they need to be looking for as they go on in life and have children. And they can obtain DNA testing to really see if they are a carrier and if there is a potential for them to pass it on to their offspring. The last mode of inheritance is the X-linked recessive inheritance. This is the most rare and least seen in case studies. There's only been a handful of cases throughout all of history, at least documented history. And this is attributed specifically to type 19 of osteogenesis imperfecta.
Now that we've gone over the genotypic effects, what are some of the phenotypic effects? How does it affect body function? In what ways does the disease present? And what other conditions might it lead to? The phenotypic effects of OI vary depending on the type and the severity of OI present. Those with the more common and less severe forms usually face issues such as increased risk of bone fractures and weakened immune systems. They must be careful to not get sick, especially in flu and cold season. Some may present with conditions affecting posture, such as scoliosis, which is the curvature of the spine. Others may have shortened heights due to shortened arms and legs. For those suffering from the more severe forms, complications can include problems with breathing and swallowing. Rib cages may be smaller and more fragile, and the lungs may be underdeveloped in some cases. In cases where the lungs are not fully developed, infants will have severe breathing difficulty shortly after birth and a high risk of mortality. Infants that pass from OI are usually affected by type 2, the most severe form. However, for the most common forms, such as type 1, most children can go on to live completely normal lives with no effect to their lifespans. While OI most often is a result of mutations to the genes responsible for collagen, COL1A1 and COL1A2, both of which are responsible for type 1 collagen production, studies have shown that mutations in a number of other genes may result in complications to OI as well. Stop and missense mutations may cause issues in bone formation and homeostasis, which is the process of bones being absorbed or built to keep bone mass in appropriate levels. Mutations in other genes may also lead to issues in bone stability due to structural malformations in collagen, resulting in brittle bones and increased risk of fractures.
With all this information in mind, what are the treatments that physicians use to help those who do suffer with osteogenesis imperfecta today?
There are several methods of treatment for OI. However, all of these are for management of the condition, not to cure, as OI does not have a cure. Treatment typically involves surgical intervention, where steel rods are put in place to stabilize bones and correct fractures. However, surgical complications do arise, such as rod migration, where the rod moves from its intended spot and can possibly puncture tissue, joints, and even other bones, causing refracturing or new fractures. Physical therapy is often required in almost all OI patients, whether to help regain joint and muscle function following fractures or to assist patients that suffer from curvature of the spine gain better mobility. An important goal of physical therapy in OI patients is helping to strengthen muscles and increase bone density, which may be beneficial in keeping future fractures at a minimum. Also in the realm of physical therapy are assistive devices such as braces, splints, and wheelchairs to assist with movement and manage bone fractures. Biphosphate medications may be used to strengthen bones as well, preventing future fractures. Common biphosphate medications include zoldronic acid, which can treat bone damage, and calcium carbonate risdronate, which alters the cycles of bone formation and breakdown, commonly used in osteoporosis treatment, stimulating higher calcium levels in bone formation. There are several methods used to diagnose osteogenesis imperfecta. Dual energy X-ray absorption, or DEXA scans, can be used to check for softening of bones. Prenatal testing methods include chorionic villus sampling at 10 to 12 weeks of pregnancy
and molecular genetic testing to check for mutations of COL1A1 or COL1A2 genes. Molecular genetic testing of OI involves taking collagen samples from small skin biopsies. Bone biopsies may be performed in which a small sample of the hip bone is taken to analyze bone proteins and bone health. This involves general anesthesia, so the patient is not awake during the procedure. Newborns may have their blood, skin, or saliva tested through blood tests and x-rays. Samples of blood, skin, or saliva can be used for genetic testing to diagnose OI, while x-rays such as DEXA can show softened bones, and regular x-rays can indicate bone fractures, which are common in OI patients following birth.
And now some additional information on OI.
Sadly, child abuse is a reality that our healthcare professionals and law enforcement officials really do have to look for signs of when they're dealing with different cases involving young children or even older children. But they also have to be careful of these cases where a child may have a form of osteogenesis imperfecta at such a mild or moderate level that if it doesn't appear in the family history before, it may be undiagnosed. So there are some steps that professionals can take when they suspect that there is child abuse in order to rule out a genetic disorder such as OI. And that would be looking at the family history, seeing if there was anyone who had similar symptoms in their medical records, or if there is a family member that is known to have OI. Another thing would be looking at the actual clinical features of the child, along with consulting a healthcare professional who has experience working with OI children directly, because some of our EDR doctors that may be dealing with these children who are in these cases may not have the level of experience, and having that professional experience from another doctor may be helpful.